Good afternoon, everyone, and thank you for joining me. I'm Matt Harmon, Vice President of Clinical Solutions here at Employers Health. A big thank you from our team to all of you for joining us this afternoon. Before we kick things off, I have a few housekeeping items that we like to go over. So currently, and for the remainder of the webinar, all attendees will be on listen-only mode. So please use the Q&A function. If you have any questions, it's on the left-hand side of the console. You can submit those questions anytime throughout today's webinar. We will address them at the end of the presentation. A copy of the presentation is available for download and can be found if you click that little paperclip at the bottom of your screen. Additionally, we will record today's presentation and it will arrive in your email at some point tomorrow. And once we're done with the webinar, it'd be great if you could fill out that survey and provide feedback. We really appreciate it. If all attendees do give that feedback, since it really helps shape us in our future programs. All right, let's get to some introductions. So joining us today is Sherry Smith, a certified oncology patient navigator at the Stephanie Spielman Comprehensive Breast Center as part of the James Center for Cancer Health Equity Patient Navigation team. Sherry's focus is on supporting and navigating patients with breast cancer through coordination of breast care and other healthcare services, which includes helping patients in underserved areas gain access to vital cancer screenings, ensuring timely cancer diagnosis and care, and working to remove barriers related to social determinants of health. Also joining us today is Dr. Bridget A, breast cancer medical oncologist and deputy director of the Center for Cancer Health Equity at the Ohio State University Comprehensive Cancer Center, commonly known as the James. Dr. Oppong is a surgical oncologist specializing in breast cancer treatment with expertise in breast conservation surgery, advanced mastectomy procedures, and innovative irradiation techniques. Our goal is to provide compassionate care that is personalized to every individual. Welcome, Sherry and Dr. Oppong.
Thank you so much for that kind introduction. Okay, so we'll go ahead and get started. I felt like somebody's freezing. Good afternoon, everybody. Again, thank you for that kind introduction. I'd like to thank Employers Health, as well as Genentech for sponsoring this event and for having myself and Ms. Smith here. So we will be talking to you about the role of health equity in cancer care. As you've heard, that's our world. And specifically, our world is majority breast cancer, although Sherry, as a navigator, will have patients with other cancer sites. So neither one of us have disclosures. I'd like to get that housekeeping task out. And as an overview, what we will discuss today, or I will start first, I like to say, so this will be a co-presentation. I'm going to start with some cancer epidemiology and disparities. And then we're going to talk about barriers in the cancer continuum from screening to survivorship. Then we're going to focus on how the patient's social environment or any individuals will impact their overall health and how this can contribute to health inequities, and then what we're doing about it. And this is where you'll really get to see Sherry's expertise, because she'll talk about some interventions, and particularly within the realm of navigation. So just to begin, it's always important to kind of know how we are as a nation as far as our cancer volume, right? So the American Cancer Society estimates that in 2024, this is the numbers of different cancers that we will be seeing in our men and women. For men, the most commonly diagnosed cancer will be prostate cancer, accounts for about a third of cases, whereas women, the most commonly diagnosed will be breast, which is also roughly equivalent, will represent about a third of cases. Now, what this means is that this is an incidence, meaning the number of new cases. And this graph gives you a breakdown of incidence based on race and ethnicity. So different races will get different types of cancers, or will get them more commonly. And some of the other differences is not just based on race and ethnicity, for example, but we will see differences based on geography. So patients that live in rural areas may have more certain cancers, specifically lung cancers, for example. And we will see these differences also along some racial and ethnic lines. Looking at trends when it comes to cancer death or mortality, we see that this is for the whole country. So in the US from 1975 to 22, we see that overall cancer mortality is declining. So this is for men as well as for women. Overall, we're doing better. And this is really because of our advancements from surgery to the different modalities, including medical advancements and radiation. So everybody's doing better. And I can tell you specifically for my specialty of breast cancer, for example, that the 5-year survival rate is now currently over 90%. So we're doing much better for everybody. Now, of course, there is disparities, meaning there's differences. You can see here there's differences based on gender. So male cancer mortality tends to be higher than female cancer mortality. And we will also see these differences based on things like race, ethnicity, as well as geography. All right, so this gives you a nice breakdown on the top 10 cancers and those mortality rates that we talked about. The statistics for Ohio is represented in the red bars, and the dark, I think that's teal, as my kids would say, or some kind of dark green, is the rest of the country. And unfortunately, as a state, Ohio tends to have higher mortality in a number of these top 10 cancers. You can see for lung, for example, we're higher than the rest of the country. In breast and prostate, we're also a little bit above the national average. Okay, so when we see these differences in mortality is what we call, again, these disparities, right? And we have to constantly look at the differences or define a health disparity, which is a difference in health outcomes. So as I've shown you, our death rates are different for different populations. So this, again, this is what that disparity is, right? This has to be compared to equity, which means that everyone has a fair and just opportunity to be healthy or to obtain their optimum health. And you can see in that cartoon there, it gives a nice way to depict sort of those differences. When we look at equality, for example, we can see that, you know, we want everybody to have a shot at something, right? We want everybody to access or to be able to see well. Now, how we do it can be different, right? So if we want equality, we want everybody to have good visualization. But with equity, we have to realize that how we can optimize any individual's visualization is going to be different. So if somebody who's shorter, they may need additional help to be able to have that clear vision. And that help can be different. Also, you see someone who's, for example, is handicapped, they're going to need some additional assistance to be able to bridge that barrier. And in this cartoon, it is a visualization. So it's a good way to think about some of the things that Sherry and I will be discussing as to how we can get our health outcomes to be equal. All right, so along with that, now that we have those definitions out of the way, we also have data that shows that not only do we have disparities, meaning that the outcomes for certain conditions are different, including cancer, but also different types of people, different demographics receive different care. So people of color, for example, will receive less transplants, specifically this is kidney transplantation, but we see the same thing with vaccinations, even things like mental health services, right? So this is where the equity aspect is really accentuated, because you can see that the access to different treatments, different services is not the same. But we also have to look at biology, for example, and this is now taking us back to the disparities comparison. And there are factors that we see that will produce a poor prognosis. And in cancer, we need to look at biology. So for example, Black women have a higher rate of a certain type of cancer called triple negative subtype. This is more aggressive, has a worse prognosis. So again, this accounts for biology, something that's not mutable, that we can't change. Excuse me, the slide is on ghost mode. But we also have to look at any individual's, what we call comorbidities, right? How healthy is that person? Because I'm going to say I recommend a certain kind of treatment, but if you're not healthy, if you're bedbound, you have certain medical problems, I cannot offer you certain treatments, right? So this leads us to the third point, which is inadequate receipt of proper treatment. Here again is the issue of access, and it's the issue of inequity. Apologies on that. And lastly, we have to look at how patients present. So there are racial, and again, this is ethnicity will factor into this, as well as geography. People come in with different stages of tumor. So larger cancers, more lymph node involvement. Then, of course, we have to look at socioeconomic factors. And when we talk about socioeconomic factors, we have to discuss social determinants of health. So these are the non-medical factors that influence health outcome. And you can, if you look at that graph there, there's different domains when we talk about social determinants of health. This can be in the domain of education. It can be in healthcare access and the quality of healthcare. So not only do you have the ability to obtain that care, but what is the quality like? You know, are you going to get the same as somebody who has, let's say, a more higher level of insurance coverage or more expensive coverage? We also have to look at economics, you know, because that's important. There's co-pays, even with insurance, there are co-pays, there's certain other fees that insurance will not cover. And if you're not able to obtain these services, you know, that can impact your health outcome. And then there's neighborhood. That's a big thing that now we're starting to pay more attention to, that if you reside in a certain geographic location, that can impact your health, because what healthcare facilities are around you, right? What kind of transportation do you have that can allow you to obtain services? And in order to assure equal health, right, assure optimal health, we have to address all of these determinants of health. We have to address economic stability, right? We have to look at income. We have to look at, especially when it comes to cancer, we have data that there's a high financial toxicity associated with cancer treatment. Even patients with insurance, remember, may not cover all of it. There are deductibles, there are co-pays. So oftentimes patients who are even not necessarily at the poverty level, you know, or they may be working, but just the toll of the cancer treatments can really sort of have them go into economic decline. We have to look at education, health literacy specifically, and we also have to look at their environment. Not only is there housing security, but what is the housing quality? What is the safety of that? And then we have to look at the social and community context, and all of that is going to really give us the whole picture of healthcare and overall health. All right, so when it comes to cancer screening, there are several tests that we have to discuss with patients. And the key is that they need to be educated. Again, back to the social determinants, we need to bridge those barriers to health literacy so that people understand the benefit of early screening. Because keep in mind that most cancers, right, well, especially when early, will not have any associated symptoms, right? For breast cancers, only at the most advanced stages is there any pain or any visible symptoms. So patients need to understand that, yes, you feel well, you're not encumbered by any adverse effects, but you still have to go get screened. And for breast cancers, we advocate for mammography starting at age 40, roughly. For cervical cancer, we tell patients to get pap smears, as well as consideration of HPV vaccination. And for colon cancer screening, there are multiple options, including the fecal occult tests, and colonoscopy is probably the most common one, but there's also sigmoidoscopy and digital rectal exams. All right, so all of these are important because that is how we get patients to the end goal, which is survivability of cancer, right? Get you to survivorship. And when we talk about the cancer control continuum, this is what we're referring to. We're referring to the first stage of prevention, of detection, diagnosis, treatment, and then ultimately survivorship. And we see disparities in all of these areas, all of these spaces. And we also have a chance to assure that we're addressing equitable access to services along all of these areas. And how we do this is through communication, surveillance, and research, because we need to identify what these disparities are. And I have an example here of triple negative breast cancer. I mentioned this earlier, as this is a type of an aggressive type of breast cancer that African American women have a higher rate of developing. So this triple negative breast cancer is the type that is hormone negative, and is a subtype of breast cancer. And I always have to remind people that there's different types of breast cancers, right? So Black women are more likely to get this type of cancer. And this is a biologic difference, right? So when we talk about, again, back to that distinction between disparity versus equity, here we don't have the mechanism right now to control the biology, right? So yes, there's more triple negative in this population. And it's along all ages, especially the younger women. And we see that along with this, yes, there's more triple negatives, but then we see that African American women are more likely to also be uninsured. They're more likely to live in socially, economically deprived areas. So these, again, we're going to the social determinants of health. All that will give you the picture of disparity, but in line, these are areas that we can change, right? So when we talk about equity, these are the things that we can address to make a person's outcome optimal. And certainly we have to address access to equal care, right? So this book came out, I want to say it's about probably 20, almost 30 years ago. Now, I talked about unequal treatment. And now I think most of us are pretty familiar, especially since the pandemic came about, of the concept of disparities and the concept of health equity, right? Because how can we be fair and have fair access to all levels of treatment? And we see that it's important to consider these concepts, because if you look at this graph, I always end with this particular slide. I end my talks with it because a lot of times what we talk about just seems very overwhelming, right? How we can't fix poverty, at least not quickly. We can't fix, housing insecurity. All of these things are going to remain. When Sherry and I encounter patients in the clinic, we know they have these challenges, and all of this is pressing while we're looking to treat their cancer. And as much as it may seem daunting, it seems like a very heavy lift, we have data that shows that if you address those, that outcomes can be the same, right? So in cancer, we talk about a mortality gap. If you look at this table, the difference between the Black and the white patients is roughly about 40%. And that difference has persisted for decades. So this is what we call the mortality gap. And so Black women are 40% more likely to die of breast cancer compared to their white counterparts. Now, what this group did that I love was that this is a mathematical modeling of the same demographic if they're matched based on demographics. So basically, if you remove the socioeconomic factors, if you remove the economic issues, poverty, health literacy, education, and you remove that and you give equal access to treatment, right? So that's the sort of the different lines. And as you do that, you can see that the lines start to converge to the point where it's ultimately the same. So basically what this says is that if you take a white and Black patient, which we know are not doing well, but if you match them based on demographic, if you match them based on presentation, and if you match them based on equal treatment, then that mortality gap goes down, right? So there is an avenue for us to address these outcomes. And what some of these interventions are currently is multifaceted. We have to look at the social determinants of health. We can't say that enough. I'm going to say it a whole lot of times, because I want this to really be ingrained in your mind by the end of this talk. And Sherry will also reinforce some of these concepts. But in order for health to be optimized, we need to address this. So it's not just the medications that you can provide for patients, right? It's not the pharmacotherapy, and that's very important. But we also have to look at their social situation. We have to look at their understanding of their healthcare. All of this is going to lead to their compliance, right? Because I can prescribe all the medications I want. If you don't take it because you don't understand why it's important to you, then you're not going to have a good outcome. And if you can't afford the medication, that's the other concept, right? If you can't afford a certain medication, it doesn't help you to have that prescription. You can see the doctor, you'll get the script, but if the funds aren't together, then it's not going to work, right? So your health will continue to be suboptimal. Let's see. So what are the things that we need to do? We need to look at the data and the surveillance, right? And I know for your company, it's going to be really important. You need to know who you're serving, what your service area is. Are there certain demographics that need particular attention? Like if your company is servicing a large immigrant community, for example, you need to be mindful of things like language, right? Because health literacy is really important for compliance. Are they from a rural area where we know that education levels may potentially be lower, right? So is your instructions or is your product able to be understood by the communities that are receiving the intervention or the treatment? And what is the makeup of those coming through the door? What are those individuals? What are the communities that you're seeing? What are those particular barriers, right? Because social determinants it's a large concept, but what that looks like is going to be different based on the individual communities. And some communities will have things like food deserts, right? So you can prescribe, and I'll give you an example, a non-cancer example, a diabetic who has a great medical regimen, right? But if their diet is not also optimized, then they won't have a good outcome. And as a physician, you can tell them, I want you to cut down on, high processed foods, for example. But if that individual lives in an area where they don't have, access to fresh foods, if they don't have a supermarket, they don't have a farmer's market, then they're not going to be able to change their diet. They're not going to be able to change that behavior. So these are all things that we all need to think about, in healthcare, whether you're the companies, you're thinking about drug management, or you're actually providing the healthcare services, we all need to be mindful of this information. And a lot of this is also helpful with data capture. So our electronic medical records need to be able to, again, capture our demographic. We need to be able to have an identification of these patients. And also what we're doing at Ohio State is that we're also embedding in the electronic medical records capture of social determinants of health, right? So, and we're not there yet. It's something that we're launching, but the goal is that every patient, once you come in for care, that we will screen for social determinants of health, so that if there's food insecurity, if there's housing insecurity, all of that we'll be able to address. And other opportunities and evidence building, we need to, everything takes money. Let's just be clear. Everything takes money. So when we look for resources, and that helps us with our research. It helps us with all of these efforts that we're talking about to address disparities and to address inequities. And we need funding. And the current administration has been really, has prioritized this, especially in the cancer space. And you can see that the Cancer Moonshot initiatives has really helped us to bolster a lot of the efforts that we're doing. There's also things from a policy perspective, such as CMS recently instituted as of January a way to bill for navigation services. So what we've done is that, like Sherry, for example, in the future, when she has a patient encounter, she'll be able to, bill. There'll be compensation. And while we don't mean to take away from what we do, the reality is that navigation is a limited resource. And it's difficult for us providers to convince the healthcare systems to continue to hire more, of these navigators, because their argument is that, well, it's not a revenue generating position, right? So we have to really work hard to convince them to continue to support positions like Sherry's. And I think with these national policy changes has made it a lot easier for us to justify. Right, so what the opportunities that we're currently taking advantage of is partnership with our local communities. And there's a desire from the communities as well, right? Everybody wants to be a part of this. People want their demographic to be healthier, right? We're all seeing the benefit of it. And I think, again, the pandemic really helped people to focus that attention on health, because there's nothing that changes your lens more than when your health is threatened. And I think we've seen the communities of color being disproportionately impacted by COVID, for example, and also showing that there was a high disease burden, high incidence of obesity, high incidence of all these other comorbidities that ended up making the COVID outcomes worse. And this also certainly included cancer, right? So we're working with the communities, we're listening to the communities, because they also have an ask, right? We go to them and say, like, what are the things that you need to help optimize your healthcare? And they'll tell us, well, again, about the food deserts. My doctor says I need to eat better, but there's no grocery stores. I don't have access to fresh fruits and vegetables. Those are sort of things that we're working with. And we're also starting young, because we need to start getting some of these health concepts into the youth, so that, again, they're also going to adhere to healthy lifestyles and behaviors. And again, this goes into our community engagement. And I hope I'm not stealing some of Sherry's thunder. Sherry? Oh, I'm not. Okay. Sorry about that. There's a bit of a gap here. I don't know if anyone
No,
knows.
not at all. Keep going.
Okay. All right, sounds good. So a lot of the work that we do involves community engagement. So we participate in a lot of health fairs, wellness events, and we educate on cancer, but we also educate on all levels of health, healthy eating, lifestyle, prevention, and you know, all things that matters really for all of us that can influence cancer, but also other health conditions. And then we also have to advocate, right? We have to work on policy. I participated with the American Cancer Society on a state. It was a panel at the Ohio State House that was attended by the governor and all of that, because they need us. They need, you know, those of us in healthcare, whether it's from the pharma companies, your particular company, and certainly our healthcare institutions to sort of guide the policy. We need to have our voice because, you know, we're kind of seeing what the barriers are firsthand. And I think it helps to have our voice heard by the government. All right. And then ultimately, we need to continue to increase our capacity by really bolstering our infrastructure so that we can focus. We can learn about what the inequities are, what the disparities are, but build equity through service delivery and program planning. Right. And this, again, takes a lot of resources. So we're always happy for support. But this now, again, with things like the Cancer Moonshot Initiative, we're able to do a lot more of this so that we can engage patients in discussions, not just about behavior modification, but things like biobanking, genetic testing. We have an initiative where we're looking to engage particularly African-American women in obtaining genetic testing for breast cancer risk. So if you've heard of Turning the Page on breast cancer, that's one of our initiatives. And we also are advocating for clinical trial participation because we know that this is another aspect, another factor that contributes to disparities, right? Because it's only through clinical trials that we're able to study how certain interventions work across different populations. And if we don't have a diverse cohort of patients in our trials, we don't get to see what the benefits are, you know? So this is something that we're also hoping to get across the community. And along with this, we're also looking to do implicit bias training. And we do this anyways, but we're really learning to do it in a better way, a way that's more effective when it comes to our practitioners and our researchers, right? Because we know we all have implicit biases, and we know that that shows up in, you know, the treatments that we may recommend. I showed you before, certain vaccines, certain healthcare services are less likely to be offered to, you know, patients of color. That's definitely an example of implicit bias. The same thing that goes for clinical trials. Sometimes we don't even ask certain patients because we're making assumptions on that individual, what they're willing to do or what they have the capacity to do. So there's a lot of work ahead for us. And now I think Sherry's up. If you'll give us a minute, we'll go ahead and transition.
So as Dr. Oppong was talking about, so social determinants of health really is a... Can you hear me?
Yes.
Yes.
Everything good?
Yeah.
Okay, perfect. All right. So as Dr. Oppong was mentioning, so social determinants of health really just, it really does affect everybody. And it affects everybody so much that it is an issue that the CDC is really working on in a broad scope. So just pretty much everything that Dr. Oppong has mentioned, it's about bringing together your community members, asking them what it is that they need. You can't go into communities and say, this is what we want to do for you. Because if you are not a part of that community, then you really don't know what the need is from being, you know, a part of where they live, what they deal with every day, the situations that come up. So really just bringing together your community, adding members of the communities that you work with and you work for to parts of your team so that they can help influence the decisions that you're making and that your companies are making, which then can contribute to policy change and law changes and a number of things along that way. So again, this kind of goes back to what Dr. Oppong was talking about. So patient navigation at its core is really a community-based service delivery intervention, essentially. So it's designed to promote better access, more timely access to treatment, whether that be cancer treatment, principal illness treatment, whatever that may be. So the initial patient navigation program was formed in Harlem, in New York, by someone named Dr. Harold Freeman. And he noticed that the Black women in his community were having issues getting access to care. So there was they were coming in for a screening and they had an abnormal screening or something along those lines, and then getting them back in treatment or additional testing was taking longer than their white counterparts. So he enlisted people in the community and just called them patient navigators, to help bridge that gap so that people within the Harlem community were working with their neighbors in order they got timely access to care. They were working with neighbors who knew the health system, who knew how to kind of navigate the roads that some people don't. We are very blessed to be a part of a very large, very wonderful health system. But if you are not a part of that health system, it is very hard to navigate. It's hard to navigate if you are non-English speaking. It's hard to navigate if you have low health equity. And it's hard to navigate if you are not from the area. So patient navigation and patient navigators can help with all of that. What I work on, and this is a study that Dr. Oppong did with some other people, but our mobile mammography team here in Ohio, in Southern Ohio specifically, there are 9 counties with no access to breast imaging. So if you think about that, wherever you are, you have to go 2 to 3 counties away to get your mammogram. If you find a lump on your breast, if you find something concerning, there is not easy access for you to have that looked at by a specialist. So our mobile mammography team works to go to those underserved areas. We provide, we take a mammography tech, we take someone who checks them in, and then we also work with women who are either uninsured or underinsured to help get them access to programs that would help cover the cost of those services. So we're addressing the barrier of access to care from their location. We're addressing the barrier of access to care from a financial aspect, because not only uninsured, but underinsured. So if you have something where you have a insurance that is a high deductible or an HSA, something where you have to pay out of pocket, and you have an $8,000 deductible. Well, not everyone can handle that. So we do have programs within the state of Ohio, national programs like the National Breast and Cervical Cancer Early Detection Program, which the state of Ohio also puts money into to help cover the cost of these screenings in order to address the barriers to care, because so many women were putting off their screenings due to not having coverage. So it just kind of takes this along the spectrum of we work with the mobile mammography units, and then we also I as a patient navigator watch the women that we've scheduled to be sure if they do have an abnormal screening that they are getting a follow-up. They're getting a follow-up call from the nursing team, or they're getting a follow-up call from me saying, okay, now you have that, let's get you up here for additional screening. What is it that you need to get up here? Do you need help with transportation? Do you need help with cost sharing? So that they're not delaying additional testing and then potentially even treatment longer than they would need to. Again, the value of patient navigation is kind of very widespread. It helps with timely access to care. It helps overcome barriers to care. Dr. Oppong and I both talked about the cost of cancer care, but it goes beyond an out-of-pocket cost. It goes beyond a deductible or a coinsurance or an out-of-pocket maximum. It goes to transportation. Do you have money to pay for gas? If gas is over $3 a gallon and you are having to come to the James from South Point, Ohio, which is the very tip of the point of Ohio in the South, do you have enough money to pay for gas for the 2-hour drive up here and then the 2-hour drive back? Do you have enough money to pay for lunch or some kind of food while you are driving here or back? What about childcare? Do you have children that are going to need to come with you to your appointment? Not great if we're going to be doing diagnostic testing on your breasts. If you have young children, for them, they're obviously not going to be able to come into the exam room while they're doing that testing. So we're going to have to explore childcare options. We're going to have to explore time off work. Do you work a full-time job that gives you PTO, or do you work at a gas station or a Dollar General or something that is within your community? What does that look like holistically? And beyond that, if you do end up with a cancer diagnosis, what does your support look like from that point? Are you going to have surgery? How much time off work are you going to have to take from surgery? If you are working at a gas station or a Dollar General or something where you don't have a full-time job, do you have access to short-term disability? Do you have access to FMLA coverage that would help offset the cost of you missing work? Do you have access to long-term childcare? If you can't raise your arms, if you can't lift over 5 pounds for however long, how do you take care of your children if you are a single parent who has no family in your area? What does that look like? So that is what navigators will help with. We can help with finding transportation, finding grants for financial assistance to help pay for gas, childcare, rent assistance, helping to pay for your utility bills. A number of our larger utility companies have medical extensions for people who have long-term illnesses. It works for cancer. It also works for people with asthma who can't have their power go out in the winter because they need to have access to oxygen or something along those lines. So it really is looking at the whole picture, the whole cost of cancer care, not just the financial cost, but what is the daily living cost involved with your cancer care. So also within cancer care, you know, sometimes you're seeing a surgeon, you're seeing a medical oncologist, you're maybe seeing a plastic surgeon, you're seeing a radiation oncologist, possibly you're coming for more x-rays or an MRI or something. Who do you call when you have a question? What member of that team do you call? That's what the navigator does. I can be one point of contact for you when you have 7 questions, and you probably would need to call a different member of your team, your care team, for each of those questions. That's when you reach out to your navigator to say, I have questions, I don't know who to ask. I'm here for. I can take that information and get it out to the care team, which then can come back either to the patient directly through their care team members, or can come back to me where I can follow up with the patient and say, A, B, C, D, E, F. Did we answer all of your questions? What do you need from here on going forward? So, and basically what this is almost like concierge care for people, for normal, regular, everyday people who just end up with a cancer diagnosis or a principal illness diagnosis. It really makes their care personalized to them. I also, have the ability to spend an hour and a half, 2 hours on the phone with an insurance company with questions about this patient's coverage. I know whether to ask about coverage for a screening test or a diagnostic test and what the difference is when patients are just calling my mammogram covered, but really what they mean is my diagnostic mammogram and possible ultrasound covered because I've already had my screening and that came back with something. So sometimes patients are getting questions to answer, or answers to questions that they're asking, but they're not knowing to ask the very specific questions. And because we're part of the healthcare team, we do know how to ask those questions and get the additional information. Excuse me. Very simple breakdown for what navigators do is cares. So we coordinate, we advocate for patients for whatever it is that they need. We remove barriers and we help find resources. We educate them. And we support them. A lot of times you hear the word cancer and you don't hear anything else. If you are coming into an appointment with your surgeon, you hear the first 10 words say, and then you're so overwhelmed with the fact that, oh my gosh, I'm going to have my breast removed or whatever that is, that you don't hear 95% of what the rest of the conversation is. And by the time you're leaving, you realize you have questions, but you don't know who to ask, or you're afraid to ask. So many people have white coat syndrome where just getting in a doctor's office is so overwhelming for them that everything just kind of falls out of their head. So we can help with all of that. We can also, if they don't have a support person who is available to come to their appointments, we can sit in with them on these appointments and say, how can I best serve you? How can I advocate for what it is that you need or the choices that you need? Do you want to have a second opinion and you're afraid to say that? That's fine. We can help with that. I can teach you how to advocate for yourself, but that takes a lot of time and effort. And if you're going through cancer care, sometimes you really need to focus on some other things before you focus on learning how to do that and become confident enough in advocating for yourself in those situations that we can help do that and make you feel more comfortable. Dr. Oppong mentioned that navigation is now a billable service with Medicare. It is under consideration, I believe, for third-party payers to also include navigation as a billable service. Medicaid is covering it on a state-by-state basis. Navigation is now a Commission on Cancer standard for all NCI-designated cancer centers. So if you have patients who are going to these centers, they are likely going to be given a navigator or can ask for a navigator to help them in these situations. So this is definitely something that you can think about as concierge care for your members who are getting services. It is a cost-sharing service, I believe, for Medicare. We're still in the very early stages of this, but I believe it falls under Part B of Medicare for cost sharing at a 20%. So it is something to keep in mind also that is still a cost to patients. Even though we are advocating for them and helping and coordinating, there is still a cost, or there could still be a cost involved, although it's not necessarily at such a high range as some other services. Navigation is also still not as widely recognized. So you will see people called patient navigators. You will see clinical people called nurse navigators. You'll often see community health workers. Sometimes you'll see patient care resource managers. So it really kind of depends on where they are within the continuum of care and what type of care they are able, or what type of service they are able to provide. I am a non-clinical navigator. So I do help kind of bridge the gap for people who don't necessarily need to see a social worker or a clinical care navigator, but I can address all of the non-clinical barriers to care. So something to keep in mind there. Excuse me. Again, this is kind of all parts of a larger puzzle. You have your community health workers who generally are embedded within the communities where they live and work, who can help with health promotion, things like getting mobile mammography services or promoting the services that are coming to them. And then you have patient navigators who are dealing with the logistical changes, social workers who are then dealing with psychosocial changes or challenges, things like mental health issues, things along those lines. And then you have nurse navigators or patient care resource managers who are often dealing with medication questions, symptom management, more clinical portions of the care continuum. And then this is my navigator card that we have at all of our community engagement opportunities, anything involving breast care, breast cancer questions. This is what is given to patients within the community. We also have navigators that speak Nepali, Somali, Spanish, something else, and I can't think of it off the top of my head, but we all have navigator cards in those languages so that we can make sure that the communities that we're in know how to get in touch with us, know that they can call us with questions about what is available to them locally. How can we sign people up for insurance or grants? We have signed people up for Medicaid. We have given people information on where to go for the marketplace to get things like that. So we're definitely, wanting to be a support to your members, to people in your communities and our communities, so that they're not delaying care any longer than they need to because they don't understand something, or they just need a little bit more help getting to whatever the type of care is that they need. So basically, just what we're trying to do here with addressing social determinants of health, and sometimes you'll hear them called social drivers of health as well, is closing the gap to really look at providing holistic care, understanding the root of those disparities, working within your sphere, your area, to address the system breakdowns and look at where the disparities are that are causing the inequities. Clinical research, clinical trials are advancing research in tumor biology with subtyping, new targets, new medications, new cancer treatment accesses, different specialty centers, different locations, improving screening utilization in risk groups. When Chadwick Boseman died, there was a real push for younger men to get screened for colon cancer. So looking at things like that, and then addressing patient comorbidities, making sure that they have primary care providers that they can follow up with, as well as their socioeconomic factors like social support, insurance, financial assistance, things along those lines. So I don't think anybody says many things better than Dr. Martin Luther King Jr. So we'll just leave it with what he said, with the true compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. So really it's about changing the system from within in order to make the biggest difference. So, so Dr. Oppong, do you have any final words?
I think that quote is one of my favorites from Dr. King, and it always sort of holds true. I just like to thank, Employers Health. I like to thank all the different players who invited us, because I think, it's about education. It's about the definitions. It's about just having people understand that I think health, I don't want to say healthcare. Health is a lot more than healthcare, right? Health is about all of these other things. It's about where you live. It's about your education. It's the whole picture, the sum total of the human being. And I think that's the revolution. Somebody had a question about how the pandemic changes. And I think the pandemic really helped us to highlight this is not new messaging. We've always known this. All of our disparities literature for the last couple of decades suggested that. It's hard to sort of control all of the racial and ethnic factors when we know that the drivers of all of these differences are really education, economics, and access to care and equity. So I'm hopeful that we'll continue this trajectory of wanting to learn more about this and actually doing something about it. And I think it is in the realm of the healthcare institutions, is in the realm of your company to, now that you have the information, how you can do it better to provide the services that you're providing. And somebody also asked about the one of the health equity index, and that is actually a CMS tool. So they have specific domains, and you can calculate this for your particular company to see how you're doing. And it includes items such as, access to screening. It includes things like access to certain medications, for example, statins in patients who are hypercholesterolemic. So those are the certain qualities that they look for, and you can calculate that index very easily to sort of track how your individual efforts are going. So we're open to more questions. I think that's the last slide. I'd like to acknowledge the Center for Cancer Health Equity. A lot of the slides actually was from a talk I gave to a group of nurse practitioners, but I worked on it with Chastity Washington. And of course, I'd like to thank my co-presenter, Sherry Smith, for taking the time to be here with us today. So we'll take any further questions that you all have, and we're happy to share our slides as well.
Sure. Yes. Thank you to you both. It was really informative and insightful presentation. I think, the messaging really needs to get out more into the employer space. So I appreciate you taking time out of your busy schedules to educate all of us. And hopefully, that will lead to better outcomes for all patients. So we do have a few more questions that have popped in the chat. And if there's still time to add some more.
Sure.
So Jessica says, thank you for the great information. Are you aware of any work evaluating the correlation between high crime areas and poor health outcomes?
Absolutely. So we actually have a great team at OSU where they've come up with an index. It's called the Social Vulnerability Index. And some of the things, it's a composite score, or another way to look at it is also something called area deprivation, right? So if you're in a highly, and that, I don't like that word because it just has a very negative connotation, but it's just like you're saying. So if you live in certain communities that have a high index of depravity, if you will, and that includes things like crime. So, in these neighborhoods, the calculations are, a lot of it is based on zip code. So we're able to calculate like the average income of the neighborhood community. We're able to look at the highest education attainment, and we're able to look at things like crime as well. And all those things are a factor. Those are, and it's so unfortunate. I tell people, the most common, the most realistic sort of way to tell. Like I have small children, for example, and everybody wants to know, well, how can I get my kid to be, a success, right? And I think the most common indicator of how a child is going to do in their life is where they live. And that's beyond everything. So all the money we spend on Head Start and all these things, it's well good and there's a place for it. But the reality is that the environment that you're growing up in is what's going to determine so much of your future, and not only your sort of academic, productivity, but also your overall health, right? So when we look at these areas of deprivation, it determines where how long the child's going to live. So longevity is based on that. Mm-hmm. It's also going to determine the cancer burden. So all of these things are tied in, such a close link between health, your overall just personal growth and your geography. So crime is definitely a part of that calculation.
Absolutely. So Corey writes, from an employer perspective, it would be helpful to understand if Ohio State or other organizations.
Yeah, I think it's something like right now.
Oh, sorry, Sherry. I guess the delay got us there. Go ahead.
Yeah, there's a delay, Sherry.
Sorry, you guys. So I think the latest research is showing that something like 80% of your health outcome can now be determined by your zip code rather than your biological code. So yeah, just like what Dr. Oppong was saying, it really all does come back to, majorly comes back to where you live and the drivers around that. So, and you really can break that down in a number of different resources available. I think the CDC also has something along those lines where you can look at neighborhoods by income level, crime reports, a number of things like that. So yeah, it really is interesting to see how much those social drivers really do affect our health and our overall health outcomes.
Sure. To Corey's question about cost comparison studies with or without patient navigation services, are either one of you aware of those?
I don't have offhand, I know data, but I know that navigation can help patients utilize healthcare in a way that's more cost effective. So along the whole treatment course line, patients who have navigators, and some of the navigation, some of the training, and I actually utilize this in a different space for our cancer patients, but there can be a health coaching component. And those are patients who receive that service. It ends up being cost savings because, they're able to be more compliant, especially if you look at a model of diabetes, right? They're able to adhere better to nutritional guidelines. They're able to adhere more to their medications, to check their blood sugars stably. So all of that downstream will definitely lead to a more cost-effective, will delay disease progression. So the end complications, reduce the risk of ending up on dialysis, which are all costly. So I don't have a particular number in mind, but definitely there's data supporting that navigation can work in that way.
Yeah, we need it. It's a complex system. I did have one question from your clinical perspective. We have employers on the line here. Are there any barriers that you
Agreed.
feel
Sorry.
That you feel that maybe employees are prohibited from, based on some of the employers' coverage decisions, and some things that maybe you'd recommend that could help patient care if some of those barriers were lifted?
I'm sorry, can you repeat that question?
Yes.
I think I'm getting.
Yeah, from your clinical perspective, are there any barriers that you feel like within employer healthcare coverage you've heard patients complain about coverage, and that there's things that you'd recommend employers can do to improve cancer care from a benefit design perspective?
Absolutely. And then Sherry, you can obviously chip in, but I think a lot of it is a lack of understanding. So patients oftentimes come to us because, we kind of tell them what to do and then we expect them to do it. And this is where Sherry is that nice bridge with kind of helping the patient coordinate that care. And oftentimes their concern is that they don't know how to engage with, the insurance companies. They don't know how to engage with the drug plans, the prescription plans that they have, and they don't know who to call. And actually, I have a patient who I had a clinic on Wednesday, And she set up a whole business of how to, especially older people, how to help them navigate the healthcare system, like how to make sure that they're getting the, sort of the best prescription drug plans. And if they have questions, who do they call? Because I think those are just the little lifestyle things that patients don't even go about. And we as clinicians, we don't get that information, right? I don't know if I tell a patient that I recommend you to get, like you're going to see them at they're going to give you a prescription for tamoxifen, and they'll give you like a 3-month supply. We don't know if you fill it, to be honest, right? We won't know that. We don't know if the patient can't afford it. Because oftentimes if you have Medicare, there's all of these, different parts and all of these copays that may come along with it. And we don't find out to maybe 6 months. I see the patient at 6-month intervals that I'll say, okay, how's tamoxifen treating you? What are the side effects that you're having? And then they'll say, oh, you know what? Well, I haven't been taking it because I can't afford it. Right. And that's when I'll loop back and try to get some resources from Sherry, some financial help for those patients. So I think that's sort of the issue with how clinically we're kind of separate from your end, like what your company would do, and the navigators can help provide that link. But I think we need to have a different way of doing it so that it works. Like in the UK and certain places that have more universal coverage, we can see all that. We can see, if the patient is picking up their prescriptions, and all of that comes back to us. In the US, we don't have access to that data. So unless someone tells me, then, I won't know how to help them or how to react. And some patients are frankly just too embarrassed to say, I can't afford, the copay, so I'm not taking the medications.
Absolutely. I'll have a pause there to let Sherry catch up, see if she has a comment.
Sherry, you must have AT&T because there's a limit on your network.
Thank you. I'm sorry for the delay. So I think all of what Dr. Oppong said, but also like patients with Medicaid have transportation assistance. They have up to 30 transportation assistance to visits per year. That's not something, transportation barrier is not something that is specific to Medicaid patients. Transportation barriers, 1 in 5 people in the US have a transportation barrier. So if you have patients who are, living paycheck to paycheck and can't afford $3 a gallon gas to get anywhere aside from their normal places, having something like using their FSA for a Lyft or an Uber voucher for places that have Lyft and Uber could be beneficial to potentially work into your options for your coverages. Having just really going in depth about what your benefits actually are. What are all of the benefits involved or included in your plan? Is navigation included in your plan? Like Dr. Oppong mentioned before, it really does have a trickle down effect. Yes, with Medicare billing, it is a cost sharing service, but we're also making sure that patients are getting to their appointment, which is limiting your no-shows. We're making sure that patients are getting access to their medications. Sometimes it's not as big of a thing as tamoxifen or a chemotherapy drug. Sometimes it's something like metformin, knowing to ask for a generic brand of an antibiotic, something that they can afford or that would be in your formulary, knowing who to call or who to talk to within your insurance company to say, this patient needs help with A, B, or C. Who can I talk to, or what pharmacies are in your network? What providers are in your network? That's a big thing. We have patients who are calling to schedule who are out of network that I can't help with a grant because if you're choosing to come out of network, that's a choice. However, I can refer you back to a provider that is in your network who also could potentially have the same financial assistance options available to you just within your network. So things like that, making sure that patients or clients are aware of the benefits that are available to them is a huge help.
Yeah. Great insight there and throughout the presentation. So seeing that we're out of time, I want to thank everybody for joining Dr. Oppong and Sherry today for their comments and preparing for this presentation and taking time out of their busy days. Thank you, everyone, for taking time out of your day to join us. I hope you and your families are staying safe and healthy, and have a great rest of your day. Take care.
Thank you.